Welcome to you all. I see that there are already 11 participants. Hopefully there will be more that will join us. So this is the EFIM spring webinar about coordination of care. And I'm your chair. I'm Barbara van Munster from the Department of Internal Medicine and Geriatrics from the University of Groningen in the Netherlands. And I will first give a presentation about coordination of care in patients with multimorbidity. And after that, Máximo Bernabeu-Wittel, who is a professor at the University of Sevilla in Spain, will give a presentation. Of course, you know him well as the chair of our multimorbidity working group. And he's talking about personalized care plans in the coordination of care. So then we have some time for questions and discussion, about 20 minutes, but you're also allowed to post any questions you have in the chat. Then I can answer them afterwards, but also, well, I think that's maybe the easiest way to do it. So feel free to ask any questions in the chat function. So now I'm trying to start sharing my screen, and I wanted to start with a short animation to show what is the problem that I will talk about. First. Hopefully you see the movie animation. So that was just a short introduction to show you the problem in a few words. And now I would like to continue with my presentation. Yeah. So as you can, as you saw, Betty has a lot of specialists that are treating her.
Barbara, we cannot see your screen at the moment.
Did you? You're not. Oh, I thought that I. Yeah. Hopefully you can see it now.
Yes, thank you.
Sorry. Yeah. So Betty has a lot of medical specialists that are treating her. In our own hospital, we did a short research to see how many specialists are involved in one patient in 1 year time. And I worked both in a general hospital, the Gelder Hospital, as now I'm in the academic hospital, the Universitario Medical Center Groningen. And you can see that patients see as many as 12 different medical specialisms, so even more specialists in 1 year time. So that is a lot of doctors. But we do not know a lot about the number of doctors patients see. We know a lot about multimorbidity and the combination of different diseases, but what it means for the organization of care, I couldn't find any numbers in the literature. And all those different doctors deliver the best possible care. So the cardiologist is treating heart failure, the pulmonologist is treating the chronic pulmonary disease, and they deliver the best possible care, but the patient himself is more often busy with other questions. What does this disease or this treatment mean for myself in my daily life? Can I stay on working? Will I become dependent? So those questions are often not answered in the consultations with the doctors. And also the patient has to combine all the different recommendations of those specialists and the different treatment regimes. He has to do that himself. The care is mostly organized via care trajectories. So they are disease oriented. And when you have one disease, that is not really a problem. When you have two diseases, two chronic conditions, it becomes a little bit more difficult because you have to combine the different appointments and medication and other lifestyle recommendations. But when there is a lot of comorbidity, there are also functional and often psychosocial problems and limitations. So then it's really, really complex, and disease management is not enough and case management is needed. Because the fragmentation of care has some important consequences for both the doctor as the patient. It's leading to an unhappy doctor because you often see poor health outcomes of those patients with multimorbidity, with more unplanned hospital admission, emergency visits, more complications of treatment. But it's also leading to an unhappy patient because the experience with care is not really fulfilling the questions patients have. They are not guided in their care and in their organization of appointments, for example, and it's leading to a lower quality of life. Also, this fragmentation of care leads to high costs. It has consequences for the health system as a whole. So all those diseases and all those doctors, they give rise to high costs, and this costs are not really normally divided across the population. If you see at if you look at the literature, especially the publication of Tanke, he showed that 1% of the population is responsible for 30% of the healthcare costs, and those patients, those 1%, are the patients with multimorbidity. Many of those costs are preventable, especially the health outcomes as emergency department visits that might be unnecessary if you plan and organize the care better. So that's why I'm talking about coordination and tailoring of hospital care, especially. And by that, I mean not only coordination tailored to the overall somatic problems, but also to the functional and psychosocial situation, taking into account the preferences, the goals, and also the possibilities, the capabilities of a patient. To show you what it is like in the Netherlands, we just finished advisory report on this subject. And for this, we looked into detail how it is organized in the Netherlands, what is already there, and what is needed for the coordination of care. We have no guidelines describing any form of coordination, so there's not really a quality standard for this kind of care. If you ask the medical specialists in our country, they say that, well, they recognize that it is needed, but it does not happen automatically. It takes time and, well, it's costly, therefore, to do it. So they're not really eager to do it, and they say, well, I think if there's somebody who should do it, it should be a generalistic doctor, like a doctor in internal medicine or a geriatrician. If you ask the patients in our country, they say, well, we really want to be in control, but it's too difficult for us, and we prefer not to be coordinated, but we prefer to have support in our own coordination. So they want to stay in charge. And they really like to be seen as a whole and have one point of contact for their care. In the Netherlands, we have a system with a good system with general practitioners for the first line care. And the idea is the coordination of care primarily is that the coordination of care is primarily done by general practitioners. However, they have difficulties in maintaining the overview because lots of the diseases and treatments are taking place in hospital, and they can't see the records, and they only get letters from the medical specialist, so it's difficult for them. And if you ask hospital organizations, they say that they have some programs that are involved in the coordination of care, but mostly it's limited to the real frail population of older geriatric patients. And the younger patients with multimorbidity, they don't get any form of coordination. So which are those patients that need coordination? You can't find it in literature because there's no screening instrument or questionnaire available for coordination need. So we looked for circumstantial evidence and looked for the patients that had a high care consumption or low patient satisfaction, so the consequences of lack of coordination. And we identified that there are two factors important. One is our patient-related factors, the complexity of the patient, so a patient with cognitive impairment or low health literacy or not much social support does need coordination faster than a patient that is really healthy on those domains. And on the other hand, there are the factors that are related to the need for coordination are the complexity of the multimorbidity. So the more diseases are there, or the more organizations or doctors are involved, the more complex it is for patients to organize their care. And then it's also important to see if those diseases are, if it's concordant multimorbidity or discordant multimorbidity. And by this, I mean, I don't know if you are all familiar with this term. So concordant multimorbidity, I mean, diseases that appear together more frequently, either by the same cause, so causal multimorbidity, that they share a risk factor, like diabetes and osteoarthritis can be both related to obesity, or because of complicating multimorbidity, that one disease is leading to the other, like diabetes and polyneuropathy, or cluster multimorbidity, where there are diseases that appear more often than expected due to sometimes factors we don't know yet. And on the other hand, the discordant multimorbidity, where there is no relation between the diseases and it's just coincidence. And doctors that are involved in discordant multimorbidity maybe recognize that they are not used to working together. They don't know anything about the field or the diseases they are working in. And if you look at the literature, there's lots of information about multimorbidity, but not so about the concordant or multimorbidity in the hospital. So that's why I really want to plea for studying our own hospital population to see what's needed not only for research purposes, but also for transforming care in your own hospital. And I want to give some examples about of things that I did myself that are also published, but there are far more examples than I show you here. So this is the triangle form that's derived from Kaiser Permanente. Well, when you have one disease, there's not really a problem. You can just do the normal care, but if there is multimorbidity, then maybe the first step is to see if it's concordant multimorbidity or not. It's just an idea. And for this, we were I searched in our healthcare records of the general hospital I worked in, and I looked for clusters of medical specialists that were involved around patient groups. So they didn't know each, maybe that they were treating the same patients, but maybe there were clusters that we could, that we are able to combine care and combined outpatient clinic trajectories. And it were about 22,000 patients with multimorbidity, and we did a clustering algorithm with a soft clustering, so a patient could be part of one cluster and at the same time a bit of a part of another cluster. And we identified, as you can see, 6 clusters of medical specialists that were treating about more than 95% of the patients were involved only in that cluster, unique in that cluster. So if you look into more detail in 3 of those clusters, as an example, there was a cluster of skin cancer where the dermatology and the it was the other way around. We saw a cluster of dermatology and plastic surgery together, and might be that those are the patients with skin cancer, and you could really combine those care trajectories. But also an interesting cluster of internal medicine, cardiology, and geriatrics. So they were not working together with those patients, but it seems that that is a cardiometabolic cluster where you can make a care trajectory about around those diseases together. And another example, neurology, physiatry, anesthesiology, which shows more a kind of a musculoskeletal diseases cluster. So that about the concordant multimorbidity. Then a level higher, the more difficult is the discordant multimorbidity, and then case management is needed. But how can you identify those patients? I showed you which patients are in need for coordination of care, and you have different levels you can look into. It's logical to see to look for patients that have that use a lot of healthcare, so many outpatient clinic visits, for example, or many hospitalizations. But you can also look in the other points that are related. So fragmentation of care is difficult to measure in your health record, but you can also see to look for the patients that make the highest costs. So the 1% that is the most expensive patient, of the patients that have a lot of adverse outcomes, or patients that are not really happy with their care, so low patient satisfaction. So I give you an example of the healthcare use. Also, we did in the same hospital. Oh yeah, and you can make a prediction model, or you can just define thresholds that you say, well, we want to look at patients that have more than 12 visits at the outpatient clinic if they need something else next to their normal care or instead of their normal care patterns. So we developed a prediction model for patients that used a lot of healthcare, and this is just an example how you can translate this prediction model to the care. If you have patient, this was an example out of the prediction model, a patient 68 years old with a medium socioeconomic status, was in 2018. He had 5 chronic diagnoses, 2 acute diagnoses, and he had many outpatient visits and also ED visits and hospitalization. If you want to predict the care for this patient, it is in the top 5% for emergency department visits and also in the top 10% for outpatient visits. So you can invite this patient and see if you can do something to prevent this care. And what is the intervention that is needed for those patients? It consists of three elements. And it's really a team effort. It's not one doctor who can do that. It's an effort of the patient himself. The patient needs help in the organization of self-ment, a fixed contact point for the patient, and a comprehensive and coordinated plan, which is more part of the specialist care. So what is the effectivity of this intervention? It's described in the NICE guideline, but there's also a Cochrane review about this subject. And all those, there are many different interventions, but they all share the same, not always all elements, but they share different combinations of the elements, that there is a good interdisciplinary communication, that is patient-oriented, one fixed point of contact, and support in self-management. So those are the 3 elements. And if you look into literature, there is especially an improved patient satisfaction. It shows that it has it leads to an improvement of the continuity of care and less acute care consumption in specific populations. So if I go into depth into those 3 elements, well, the self-management, maybe it's more spoken into in the next presentation, but you need to help individuals to live well with their chronic conditions or do something about advanced care planning. Case manager, that is the goal of case manager, is to increase access to healthcare and improve in continuity and the effectivity of this care plan. She or he is the primary contact point for the patient or the family. It does not have to be a doctor necessarily. It can also be a nurse. And he or she is the access point to the care system. It's a coordinator between the patient and the total multidisciplinary team, and it guards the continuity of care, follow-up, and the documentation. So if you look at the effectiveness of case management, there are, this is a review, a bit old already, we're also in first line, also transitional care out of the hospital after an admission. And the case manager are different persons. Duration also differs across the studies, but it had no effect on unplanned hospital admissions. However, it was effective in reducing hospitalization duration and use of hospital care. But it depends. I don't think you should do case management as a lowly element. You should combine it with the other elements of coordination. Then the comprehensive coordinated treatment plan. Now this is well described in the NICE guideline, and also there's an ATS plan for that. So you should make a plan what's not only including the somatic diseases and treatment and medication, but it should be based on the biopsychological functioning and matching goals of the patients and the preferences and their possibilities, with specific support for the patient, for the coordination itself, with multidisciplinary consultation with colleagues, not only writing letters to each other. And in this treatment plan, it's important to see if you might be able to take over care of other professionals. So you can measure the blood pressure for the cardiologist and only ask the cardiologist if he's really needed, because maybe it's not necessary that the patient goes to all those different specialists. And if you do a consultation and make a consultation letter, write also something about your treatment goals that are agreed with the patient, what are the other healthcare providers and what are they exactly doing in their treatment, and who is responsible for what, and share that overview with the patient. So this takes a lot of time, and that's the next problem. I will finish. This is my last slide. I see I'm over my time. Because it takes a lot of time, the preconditions are not yet there, in our country at least. So there's no financial compensation for coordination of care. There's no integration of health and the social care. So that should be organized on a national level, including quality standards, what it should look like. For the hospital, it's needed that they provide you with a health record with good care overview, and help in the identification of patients that need this coordination. But also on the patient and doctor level, they both need education and awareness of this problem, get motivated to do something about it. And we need more scientific research, because there's not much. There is some research done, but not much yet. So we should share and bundle our initiative, and that's exactly why I'm happy to share this with you and discuss it afterwards. So this was what I wanted to share with you. I hope you could follow it, and I'm going over to the chat. There are no questions yet, so I think we should just continue then with the next presentation. Thank you very much for the possibility to share this with you, and I would like to invite Máximo to go on with the presentation.
Thank you very much, Barbara. Thank you for your nice presentation, and thank you for sharing this webinar, this spring webinar of our working group. Thank you to Delta Communication, and of course, thank you to the EFIM Academy to make this webinar possible. Do you see my slides? I think so. All right, in the following minutes, in the next minutes, I will try to let you know about personalized care plans in the coordination of care. And I'm willing to solve this question if they are nowadays or currently a realistic solution for our patients with multimorbidity. And for this, I have built this roadmap of the items I will treat. First of all, I will present you what is a personalized care plan, or what is working with personalized care planning. Then we will talk about why it's important, or why should we work with personalized care planning, or establishing this new model of working with with patients with multimorbidity. Then we will move to the issues or the features that we need to correctly build a personalized care plan. And finally, we will try to answer this question if this new form of clinical work together with patients is a realistic solution nowadays. So a personalized care plan is a collaborative process among clinical team. And when I say clinical team, I refer to all members of clinical teams, all specialists, a primary care physician, nurses, and even social workers, and the patient with his or her environment, mainly his or her caregiver. This collaborative process or a discussion process, the clinical team and the patients and his or her environment identify and discuss about his or her health problems, establish priorities according to patients' preferences, and then they agree about objectives and goals for the future of the patients, engaging then the actions, the controls, and the future diagnostic procedures and treatments. And finally, all these conversations are recorded in a template or a document which is shared with the patients and all clinical team. Well, personalized care planning is one of the cornerstones of what is called personalized care. Personalized care is a new trend in delivering health care to mainly patients with chronic conditions or patients with multimorbidity, which has been developed and is well developed in many countries. And as you see here, the main idea of personalized care is delivering a friendly healthcare to what matters to patients. These are the main components, as you see here in this round of personalized care. And as you see here, one of the main components or instruments or tools in delivering this new model of healthcare is the personalized care planning together with patients and the clinical teams. And why working in this new form of clinical care delivery with patients with multimorbidity? As you see here, and as Barbara has already commented, these patients with severe multimorbidity or with severe complex chronic condition are in the top of the Kaiser Permanente pyramid, and this population is indeed the population who can mostly benefit from personalized care. Nowadays, it is estimated that they are around 5% of the whole population. In England, in which personalized care is already very well developed since at least 10 years, they have built or constructed a new and global patient-oriented model of care, as you see here. And if we go up to the complexity pyramid, we can see all interventions, all progressively included interventions. And in the top, where our patients with multimorbidity are, what is recommended is to really offer patients a model of personalized care planning. Well, but let's go to the reality, to our clinical practice daily. I bring you a vignette of a citizen, an European citizen who lives in the south of Spain. His name is Antonio. He's old. He is an ex-smoker, has hypertension, diabetes mellitus, dyslipidemia, obesity, and he also has 3 important organ diseases. He suffered from COPD, from chronic heart failure, with a last admission 6 months ago due to COVID-19, which was complicated with a heart failure exacerbation. And he suffers also from chronic kidney disease. He takes daily 15 medications. He's independent for basic activities of daily living, but dependent for instrumental. He has no cognitive impairment and lives with his spouse, and he has 2 sons who live nearby. He goes regularly to primary care physician, cardiologist, nephrologist, pneumologist, and also an internist geriatrician. If we draw in a figure our current model of care, we can guess he has a narrow relationship with his family physician, but he also goes to the cardiologist who performs different diagnostic tests and treatment plans. He goes also to the pneumologist the same way, to the nephrologist, and to the internist and geriatrician. Probably neither of these specialists have the opportunity to share information or to share opinions or to make consensus with respect to Antonio. And of course, probably they don't have an easy way to contact with his family physician. But this is not only the only issue, because Antonio, due to his 3 important chronic conditions, may become unstable and may be exacerbated. So it's probably that he will need hospital admissions, 1-2 per year, and in these hospital admissions, a new niche of incommunication or of isolation appears with new diagnostics, new diseases, new treatments, and plan changes which can interfere in all his healthcare process. So in the end, we have the image of Antonio not in the center of the figure. In the center of the figure is the system with the specialist and the hospital and the primary care center, and the image of Antonio becomes a little bit blurred and, of course, out of our focus. And what is the aim or the vocation of personalized care and personalized care planning with respect to Antonio? The main vocation, I think, is to put or to set Antonio in the center of the process. And all the healthcare team, including hospital admissions and all specialists, working together in the health of Antonio in a different model of which we are accustomed to work nowadays. The solution is to join efforts together with efforts of Antonio, and this is the main idea of this new model of work, which is personalized care planning. So a personalized care planning puts Antonio and patients with multimorbidity in a central position. It is anticipatory, proactive, and collaborative in a different way as we are now working in our system. We are working in a delayed way, reactive way, and not collaborative way in the management of these patients. Personalized care planning puts in value the multidisciplinary clinical team. The patient takes an active role in the decision-making. Decisions are always shared. Self-management and patient activations are promoted. It's important the involvement of family and social network. And of course, what we expect, the results we expect for this new and different model of care is a change in healthcare behaviors and health service use from Antonio. And what do we need to correctly build a personalized care plan? Well, I bring here you a document of recommendations who was written in 2016 in our Andalusian healthcare system by Ollero and collaborators, in which they established the most important recommendations to shift, to make the change, to change our way of working with patients with multimorbidity. There is a pre-intervention work to do, mainly assessment of geriatric conditions and prognostic assessment and pharmacological assessment and the assessment of the degree of activation and the preferences and values of the patient. Then it is followed by a process of building the personalized care plan in a series of conversations and clinical rounds with the patient and his family, as you see here in 7 steps. And the process ends with an adapted and completed template, which is shared as format of document or PDF document or a clinical document shared among the patient, the primary care physician, social workers, and all clinical team. But it's not so easy. If it were so easy, this speak would be redundant. We have much to do to make this change, to shift our way of delivering healthcare to these patients. We need a lot of things to make possible working or make possible the task of personalized care planning. Just you see here in the right of the slide. We need first these 5 criteria. Patients should be central in the process, and we have to believe in it, and the patient has also to believe in it. Patients should be proactive. Patient should have a shareable record of his personalized care planning, which needs investment in technology, investment in medical records, and time. Patients has to agree on the outcomes to achieve, and the patient should be able to review her personalized care plan. There are also very important the system enables. If we don't enable with these 5 conditions the change will be impossible, as my own experience. We need health authorities who should be aware of the process and support the change. They should promote coordinated care. The medical records should be, of course, digital and shared among levels of attention, among hospital, primary care, social workers. We need a change in our culture to a culture of teamwork, which is not so introduced in the medical profession. And of course, we need motivated and engaged professionals. And what role could have we as internists in this new model of care, in personalized care? Well, here I bring you a set of emergent and emergent tasks and targets for the optimal management of multimorbidity, which was published by our work group recently. And as you see here, all of this, I think you agree with me that they are in our DNA as internists. Together with our classical competence makes us a very valuable figure for this task. So I will say we as internists have the opportunity to be in the front line with when this change comes, and it probably will come in the future years. So we should take advantage of what we are, what we know, our know-how in the management of patients with multiple conditions. It is also an opportunity for the development of our specialty, of course, in a co-protagonist role together with primary care and geriatricians. And if we don't take up this task, I think others will come and do it. And this is the last question I am trying to solve or to answer. The question is, well, Máximo, this is very beautiful. Personalized care planning is a very big idea. Personalized care is really nice for this patient, but it's a realistic solution nowadays. I have found this Cochrane review is one of the most complete review I have found regarding personalized care planning. It was published by Coulter and collaborators in 2016, and they review 19 randomized clinical trials with more than 10,000 included patients with a wide range of diseases. Diabetes, hypertension, asthma, chronic kidney disease, heart failure, COPD, and the conclusions of authors are summed up in this sentence as you see here. This sentence, you can say, well, Máximo, this sentence is the same as saying nothing. So you have dig in the document and read really the different aspects they evaluated, and they concluded that personalized care planning obtained better controls in glucose level, in blood pressure, in patients with asthma. It showed also improvement in mood and anxiety disorders. Also a higher confidence in self-management of patients, but it has no effect on cholesterol levels, BMI, and quality of life, surprisingly. Of course, no harms of the intervention were detected. They concluded that the best outcomes were reached if preparation, record sharing, core coordination, and review were present. What is the same when support was more intensive, or what is the same when we dedicated more time to our patients. And this is the question, is feasible nowadays? I bring you here the 4 golden T's of personalized care planning: teamwork, transdisciplinarity and interdisciplinarity, of course, technology, shared medical records, and the 4 and the most important for me, and probably the which we are more scarcely, this is time. So this is the utopia. This is what it should be for working with personalized care planning, but we face nowadays with the reality. Reality is not so beautiful. We are professionals in a busy world, overwhelmed, and after the pandemic, we are stressed and agitated. The system is oriented yet for acute episodes and not for chronic care. It's still scarcely integrated and is not oriented to a really teamwork. And this kind of patient, this population is emerging. Nowadays, they are 5% of the population, but probably in the future years, they will be 10 or even 15% of the population. So if we want to really work with personalized care plans, we will need a huge amount of time, a huge amount of human resources. And this is our reality. So this is my last slide. I want to share with you my main messages to take home. Personalized care planning is a new tool to manage patients with multimorbidity. The main idea is to put the patient in a central position or a central role in the whole process. The personalized care planning is established or structured with teamwork, and we as internists could have an important role if this new model of work arrives in the future. And as I said in the last slide, it is a beautiful utopia, but nowadays it is scarcely possible, but don't say it is impossible. Say just, I have done it yet. Thank you very much for your attention. Barbara, thank you for your patience with my English. And I'm glad here to answer any questions or comments.
So thank you very much, Maximo, for your perfect English. It was really well understandable. It was a nice presentation, also with our duty that we have, our important tasks for the future. And I see that there is a question from Sabine Valenta, who says, how have you solved these barriers? Is basically financed in your department or hospital, or do you use any technology? How do you do it?
Well, my answer to this question is a little bit sad. Nowadays, we are not working with personalized care plans. We started in 2016. We make an huge efforts to establish personalized care plans to a percentage of our patients with multimorbidity, together with primary care and other specialists. There was a political and health authorities' interest in this change in our way of delivering healthcare, and we took the task. We made the effort, but after 2-3 years, changes changes in political authorities came. This model of delivering care was for the new health authorities not so interesting, and the initial promotion of these efforts went down, and finally it ended. So nowadays, I have to say, we have no personalized care planning format of work with our patient. That is really sad. My experience with this is a good experience when we put together with primary care physician, the patients and other specialists, but it's a very, very big and difficult change in our routines. And we, in every step, had difficulties, and finally, we didn't manage it.
So this does not sound very hopeful yet, but I don't know. I'm very curious if there's somebody in the audience, maybe from a country where there is more. Sorry. I'm curious to see if there's somebody in the other audience that has it well organized, that is a bit more hopeful. For myself, I have to add to what you said, Maximo. I'm also not hopeful at the moment, but well, the way we are trying to implement it is, well, I'm making quality standards. So I'm have a kind of description what is needed for internal medicine, a guideline. So that helps that there's at least something, although it's not implemented, where they have to, you know, which they have to do, like quality standard. And the other thing I would like to add is to do research in this field, because if you can show that implementing PCP leads to less costs and less use of healthcare professionals, because I think if you do it, organize it well, you need less healthcare professionals due to well, taking care for each other's healthcare, and also because of patients that you prevent coming to the emergency department. So in the end, I'm convinced that it's cheaper and it's better for the patient, but we have to show that. And at this moment, it's difficult to get grants on this subject, because they are mostly oriented at one disease, or not this complex care organization. It's transformation of care organization. So I think also the science and the quality standards can maybe help to force the field and to reorganizing our care system.
I fully agree. I think we have to put the scope in the long run with PCP, because we are treating chronic conditions. So putting our scope in the short, in a short period, probably will end with no changes in routines, changes in medical services use, but in the long run and well performed, I think I fully agree with you. The problem is that health authorities and politicians, mainly, or at least in my country, don't have this scope for the long run. They have a short scope, an electoralistic scope from the next elections. So, and they decide where the money goes, and they decide the healthcare politics in the macro. Mm-hmm. And that's really sometimes, as we have suffered in our own bodies and minds with PCP, what happened to us with this initiative.
Okay, I see that there are no more questions in the chat. So and it's 2 minutes before, so I think we can finish this really nice webinar about the coordination of care. I hope you have learned something and you take something home with you, and try to also be busy implementing these new form of care in your own hospital with your own patients, and start tomorrow by offering it to your patient if it's possible. If you do one patient a day offering this PCP, it's also helping. To start small and then go for the complete population. I would like to thank all the audience, but also the EFIM, and of course Maximo for his very nice presentation. Thank you. and see you in the next webinar of the EFIM Multimorbidity Working Group. Bye.